Good morning. Good morning. Good morning. Good morning. Good morning. Welcome to another PM session. Well, I know Before we begin, we will start as we usually do with a word of prayer. Father God in heaven, we are so thankful for life. We are so thankful for health and strength. We are thankful for this another day to learn, another day to grow, another day to give back in service. We ask you to be with us as we continue on this educational journey. Be with the speaker as she help us to enhance our knowledge. This I pray in Jesus' name. Amen. I am so excited for us to continue in our conversation as we continue in our Matters of the Heart series in recognition of Heart Month. If you were here to our last CME session, you would have met our dynamic speaker who did a wonderful job and brought us a very exciting case. She is here again with us, Dr. Rogeolle Morris, who will be discussing with us today management of new onset atrial fibrillation. So please welcome Dr. Morris as she enlightens us today. Dr. Morris?
Morning. It's such a pleasure to be here again to share with you guys on the last Friday of Heart Month. It's been a very hectic month for me, but very productive. I've been able to hopefully impact some lives along with helping to bridge the gap in terms of gaps of knowledge to my colleagues. And hopefully I'll do the same again today. Can you guys see my slides? Just want to confirm.
Yes, we can see them.
Okay. Is it in presenter mode or you can see just my...
Yes, no, it's in presenters mode.
Okay, let me just take that out then. Okay, for those of you who don't know me, I'm Dr. Rogeolle Morris. I'm a cardiologist and a cardiac electrophysiologist. And I hope that today I can approach AFib not as just a simple arrhythmia, but also use this as a way to bridge the gap between the systems levels that are affected in our hospital, because AFib affects all of us throughout the entire hospital. Starts in the emergency room, goes through to our internists, and also impacts our surgeons as well, our anesthesiologists, and even myself as a cardiologist. So today, hopefully, we can apply a 10-minute assessment framework for how we approach atrial fibrillation when it comes to new onset. So today, I'm just kind of focusing on new onset atrial fibrillation as opposed to chronic AFib, and how we can determine whether or not we choose a rate versus rhythm control, and how to safely anticoagulate patients, especially those who will undergo surgical intervention or those who are post-operative. And also look at how we approach or navigate some controversies in the ICU, as well as post-operatively, and look at atrial fibrillation in some special cases as well. And then hopefully standardize the way we manage AFib and what should be our referral pathways as well. So why AFib? So AFib is a hospital-wide problem. It's the most common sustained arrhythmia, and it utilizes a lot of our resources and readmissions. I'll actually give you from the United States the amount of money that they spent on atrial fibrillation in 1 year, and it's quite shocking. And then also noting that atrial fibrillation has with it an associated morbidity, and we're talking more specifically about strokes and their debilitating impact, not only on an individual, but also families and the economy, as well as heart failure, decompensations, and also perioperative complications as well. And AFib also, there's this wide variation in practice. And I think the aim is to prevent harm and also to reduce the associated complications that we experience with atrial fibrillation. So the prevalence of atrial fibrillation is actually quite shocking. 50 million people were estimated to have atrial fibrillation worldwide in 2020, and this underestimates the number of patients who had AFib in 2020, because there are some people who actually have atrial fibrillation and they're undetected, and simply because patients present very differently. Some people are symptomatic, and there are some patients who are asymptomatic with their atrial fibrillation. The shocking news is that no matter our risk factors, well, it does matter, but the fact is that atrial fibrillation is a disease of aging, and our population is aging. And overall, you have a lifetime risk of 1 in 3 in terms of developing atrial fibrillation. And atrial fibrillation is also associated with increased risk. There's a 1 to 2-fold risk of death, and almost a 3-fold risk of developing a stroke. And atrial fibrillation actually accounted for 28.4 billion per year in the US healthcare spending just in 2016. And I'm sure that has actually doubled since then. And we will probably see the worldwide estimate of atrial fibrillation in 2030 to be actually 100 million, which is shocking. So I don't usually just see atrial fibrillation as an arrhythmia. I also see it as an atrial myopathy. And the reason for that is that we often say atrial fibrillation begets atrial fibrillation, and I think we underestimate that statement. And this is because once you have atrial fibrillation, or you have the trigger for atrial fibrillation, often starting out as a foci within the atrium, most times within the left atrium, this triggers you to have different foci within the atrium, and then developing into this very disorganized arrhythmia, because there's triggers, there's a substrate, and there are also modulators, so things that precipitate atrial fibrillation occurring. So there's electrical remodeling, and electrical remodeling leads to structural remodeling, and structural remodeling leads to fibrosis. And again, that cycle goes on in terms of more electrical remodeling, more structural remodeling, more fibrosis. So that's initiating the talk on, or the subject of, what is the pathogenesis of atrial fibrillation. As I said, there's a trigger, and most times the trigger occurs in a venous structure that is within the heart itself. So as electrophysiologists, we know that most of the triggers do arise from the pulmonary veins, and this is because in embryologic life, the pulmonary veins and the left atrium were one structure, and as you developed in vitro, or as you came from the embryonic stages of life until you became a fully developed baby, the pulmonary veins and the left atrium separated. So there is some tissue within the pulmonary veins that is like atrial tissue. And this is where we believe the triggers for atrial fibrillation arise from. And that's why our ablation strategies are utilized to electrically isolate the pulmonary veins from the left atrium when we do an atrial fibrillation ablation. But these are not the only triggers, and that's what is challenging when it comes to doing an atrial fibrillation ablation. And that's why most studies quote that in atrial fibrillation ablation, the success rate is only somewhere between 75 to 80%. And it doesn't matter if you have a redo atrial fibrillation. I've had patients who've had at least 5 atrial fibrillation ablations, and they still continue to have atrial fibrillation. And the reason for that is that the triggers are not just localized to the pulmonary veins. There are other venous structures, including the coronary sinus, the superior vena cava, the inferior vena cava. And these all can trigger ectopic foci. And this causes electrical atrial remodeling, and then this leads to fibrosis. Your extensive fibrosis again leads to more electrical remodeling, as I said. And the substrate is mostly your atrial dilatation that occurs with atrial remodeling. And modulators include inflammatory processes. So if this patient has an underlying infection, they're septic, they're hypoxic, they're undergoing surgery where there's a catecholamine surge, all of these things can precipitate atrial fibrillation. And as we know, atrial fibrillation occurs almost on a spectrum where it starts out initially as paroxysmal atrial fibrillation, and then eventually leads to persistent and then long-standing persistent atrial fibrillation. So this is just a flow chart that looks specifically at how each of the risk factors associated, well, not all of them, but some of the risk factors that precipitate atrial fibrillation and how they do so. So for example, hypertension and valvular disease, more specifically mitral valve disease, MS and MR, the way they lead to atrial fibrillation is through the renin-angiotensin-aldosterone pathway. And once this becomes activated, it causes a fibrotic and adipocyte signaling that develops into this slowing atrial conduction, which then leads to atrial fibrillation. As it relates to obesity and obstructive sleep apnea, and that's why this is something I'm kind of passionate about in terms of obesity and its relation to atrial fibrillation. You get these metabolic and mitochondrial dysfunctions, which lead to oxidative stress. And then this oxidative stress leads to an inflammatory activation using the NLRP3 inflammasome. And this then leads to systemic inflammation, again, with these slowing heterogeneous atrial conductions, which we know to be almost like atrial ectopics. And then this leads to atrial fibrillation. So there's also a role of the autonomic nervous system and leading to atrial fibrillation. There have also been some studies where they looked at trying to denervate the autonomic nervous system as a way to treat atrial fibrillation. The success of this, again, is not that great. And we know that most of the success when it comes to freedom from atrial fibrillation, most of it is with utilizing ablations via the pulmonary veins. But these autonomic triggers increase adrenergic nerve activity and increase cholinergic nerve activity, which leads to automaticity, and both early and delayed after depolarizations, which then lead to electrical fractionation and atrial fibrillation. And this is mostly trigger-based, and with time, it goes from paroxysmal to permanent atrial fibrillation. There's also genetics associated with atrial fibrillation as well. I've seen quite a few young people. And there's also atrial fibrillation associated with athletes as well. I don't know if these are on a continuum or they overlap, but it's quite shocking to see because I've seen young people as young as 20 years old who may be athletes and they develop atrial fibrillation, and they do have family members who also have atrial fibrillation occurring at a young age. The genetics associated with atrial fibrillation are not all known, but some genes have been identified. And these are usually rare genetic variants within the myocardial proteins, and they play a role in atrial fibrillation onset. And as you can see here, there's these particular genes associated with cardiomyopathies, and specifically not just arrhythmias or atrial arrhythmias, but there are also ventricular arrhythmias associated with like your LMNA and your KCNQ1 genes. So as you can imagine, atrial fibrillation in itself, from a pathogenic perspective, is actually a quite difficult disease process to deal with. And, we have to look at ways in terms of how to detect atrial fibrillation. And of course, our first thing is to utilize the ECG, but there are also biological markers that tell us whether or not a patient may develop atrial fibrillation. And most times it's atrial ectopics. It could be an ECG marker as simple as prolonged a PR interval, or somebody who has left ventricular hypertrophy. We do know that hypertension is a risk factor. And other markers such as an elevated brain natriuretic peptide, or your interleukin-6 or tumor necrosis factor alpha, or lipolipoprotein little a. These are biomarkers that can tell you that a patient may develop atrial fibrillation. And of course, we know the cardiovascular and non-cardiovascular risk factors. So non-cardiovascular would be like chronic kidney disease, obstructive sleep apnea, sepsis, pulmonary disease, PEs, and COPD specifically. And then, of course, the post-operative state where you have this catecholamine surge. So just going to highlight a case that I had with a patient who was admitted to the internal medicine service recently. We actually kind of discussed this case only 2 days ago, but it was a 63-year-old guy who is a carpenter, has no known medical illnesses, presenting to the emergency room with a 6-hour history of palpitations. His blood pressures were within normal range, but his heart rate was 158 beats per minute. He actually he presented to another urgent care facility and was also found to be in atrial fibrillation, initially labeled as atrial flutter because he had a coarse type of atrial fibrillation. And he had no heart failure as well. So the question is, how do you manage a patient like this? So I think in the initial phases, in terms of investigations, he had your usual complete metabolic profile. He had a complete blood count. And he went on to have a CT pulmonary angiogram. And, this is something that we don't often do, especially if somebody has normal saturations. But eventually he ended up having a bilateral pulmonary embolus. And strange enough, he had no recent travel, and this was almost like a unprovoked pulmonary embolism. So he got admitted to the ward, and eventually he ended up having a drop in his saturations, requiring oxygen, and had an echocardiogram that showed severe reduction in his systolic function with an ejection fraction of 25%. And the thought process is that he had a tachycardia-mediated cardiomyopathy. And that is kind of, interesting to think of, considering that most patients who have atrial fibrillation, if they are going to have a tachycardia-mediated cardiomyopathy, it means that they've had atrial fibrillation for a long time and they've been tachycardic for a while. So 6 hours is a very short time to develop a tachycardia-mediated cardiomyopathy. And then often as a cardiologist, sometimes I don't know which is first. Is it the chicken or the egg? And either way, we managed him for his cardiomyopathy. And I'll kind of take you on a journey where how we manage cases like this, where this patient has a cardiomyopathy associated, what we may believe, whether it's with atrial fibrillation happening first or atrial fibrillation happening afterwards. So the first 10 minutes, this is my universal approach, and I want you to develop it as well. So is this patient hemodynamically stable or not? That should be the first thing in your mind when you see a patient. And then look at what could have triggered this atrial fibrillation. Are they in shock? Is there underlying ischemia? Do they have pulmonary edema? And then also do a 12-lead ECG. You should differentiate between whether or not this is just a regular SVT, AFib, A flutter, or even AFib with WPW. And as I said, focus drivers like sepsis, bleeding, PE, thyroid disease, alcohol, and then doing your lab investigations, your complete metabolic profile with troponin and thyroid function tests, because we do know thyroid disease can be a risk factor for atrial fibrillation. And then the last arm is deciding whether this should be a rate control versus rhythm control strategy. Obviously, if the person is hemodynamically unstable, the first strategy will be a rhythm control strategy. And then we need to look at stroke prevention based on their stroke risk. So this was adapted from the ACC/AHA Heart Rhythm Society guidelines. So as I said, the first thing is this person hemodynamically stable? If the answer is no, then you do direct current cardioversion. That's a class 1 recommendation. If yes, they're stable, then you want to find out, do they have is there evidence of heart failure? If the answer is no, then you can just kind of rate control them, use beta blockers, verapamil or diltiazem, which is class 1, and then use DIG as well as amiodarone, which is considered to be class 2B. If they are in heart failure, the only drug recommendation is that of IV amiodarone. Verapamil and diltiazem in these cases are actually quite harmful and are thought to either cause shock and can cause ventricular arrhythmias. So the immediate action, as I said, for unstable AFib is to do synchronized cardioversion. Do not delay and give anticoagulation prior to this. The person's hemodynamics depend on you doing synchronized cardioversion. And then treat any underlying causes. So sepsis, hypoxia, ischemia. And then you also want to correct electrolyte abnormalities as well. And as I said, cardioversion is considered a class 1 recommendation based on the 2023 heart AFib guidelines for ACC/AHA HRS. The other thing that I do when I see a patient who comes with an arrhythmia, I often tell myself I want to make sure that this is atrial fibrillation versus atrial flutter, because we do know that atrial flutter is actually a quite difficult rhythm to deal with from a pharmacological perspective. Atrial flutter actually responds very well to cardioversion, but also very well in the long term to ablation. It's an easy ablation to do, especially if it's typical atrial flutter, which we do know is a right-sided flutter, and it is a macro reentry circuit, which involves the cavo-tricuspid isthmus. So you just kind of create a line. The cavo-tricuspid isthmus is thought to be an island of cells or area within the right atrium between the tricuspid valve and the inferior vena cava. And the ablation strategy is just to create a linear line of block within the right atrium, and that cures atrial flutter. The success of this procedure is about 93 to 95%. So this was a very common rhythm problem that I used to do in my fellowship. And I think this is something that hopefully it can bring here to Bahamas. So if it's flutter, as I said, it's harder to rate control, but easier to cardiovert. So you want to find out if this is fib versus flutter. So the thing about rate and rhythm control is there has to be a decision framework. And the reason why I say this is that not every patient is treated the same way. And I think we have to have lots of discussions, especially with patients and our healthcare team, as to whether or not this patient would have a preference for rate versus rhythm control. So I usually consider a rhythm control strategy first when the patient is symptomatic. And I use a specific score called the SAF score, which is the symptom of atrial fibrillation score, which was developed in Canada to determine how significant a patient's symptoms are with atrial fibrillation. And I want to consider a rhythm control strategy for anybody who has new or early atrial fibrillation, because the earlier you do a rhythm control strategy, the longer that person will remain into sinus rhythm before they develop atrial fibrillation again, because they probably will. And my rule of thumb is that if I see a patient and they have atrial fibrillation for the first time, I often say, let's get this patient back into sinus rhythm. If a patient has heart failure, and I'll show you the trials associated with this, if they have heart failure or tachycardia-mediated cardiomyopathy, there's now a class 1 recommendation to have this patient undergo a rhythm control strategy versus rate control. And obviously for younger patients, because it's uncomfortable for some patients. And for younger patients, they will have a lifetime risk of having AFib for a longer time versus somebody who develops atrial fibrillation after age 65. And as I said, the rhythm control strategy early is a high class recommendation. So this is class 2A. So the RACE trial, RACE 2, looked at how we should approach rate control, especially within a patient who's within hospital. So a lenient rhythm control strategy was thought to be better because it had improved overall outcomes, as you can see here. And obviously, patients will, when we say lenient, we talk about a resting heart rate of less than or equal to 110 beats per minute. And I think that if we consider a rate control strategy that is more aggressive, patients tend to become hemodynamically unstable. And of course, we want to also include patients who are within the ICU, and we want to avoid reflexively suppressing their compensatory tachycardia. So you might even be more lenient than 110 beats per minute. So agent of selection is dependent on the patient's underlying diagnosis. So if they have a normal EF and they're stable, beta blockers, diltiazem, verapamil are actually quite fine to use. If they have heart failure with reduced ejection fraction, beta blockers and amiodarone are preferred. And if this patient is hypotensive, you want to avoid your vasodilating calcium channel blockers and only consider amiodarone. And if this patient has WPW, you want to avoid your AV nodal blocking agents. And in general, the rule of thumb is if this person has heart failure with reduced EF, you should avoid the non-dihydropyridine calcium channel blockers altogether because they're harmful. So in special populations, when we talk about patients who have underlying Wolff-Parkinson-White syndrome, we know that AFib, pre-excited AFib, is something that you should never miss. And we can see an ECG here to the right with a delta wave and an irregular rhythm, and it's wide complexed. You should think about pre-excited AFib. And the reason we should never miss this is that if we give them AV nodal blocking agents, they can conduct faster down their accessory pathway and develop VF and actually die. So in these cases, you want to cardiovert them, and you also want to use IV procainamide. If there's none, then cardioversion will be the strategy of choice. So how do we apply the algorithm? So we go back to our case with the 63-year-old carpenter who came in. He was stable initially and eventually developed some signs of heart failure. I think the options are, do we rate control? Do we use a rhythm control strategy and anticoagulate? And then eventually think about what his long-term plan will be. I think for him, what we did was we initially rate controlled him, and it proved to be quite difficult. And because his EF was reduced, we opted to apply a rhythm control strategy. So he got electrically cardioverted. And then he did well and was discharged from hospital. I think one of the things that I don't think I've mentioned yet, but a very difficult thing to do prior to us doing electrical cardioversion was his anticoagulation length of time. So he was only anticoagulated for 2.5 weeks. Generally, we say patients should be anticoagulated for 3 weeks prior to cardioversion. If it's going to be less than 3 weeks, usually you want to do a transesophageal echo to determine whether or not that patient has a left atrial appendage clot before you go ahead to do this. We were quite lucky because we had anticoagulated him for a long time. And also, he also received thrombolysis for his pulmonary embolism. So I think for him, he was pretty well covered. So I just want to talk about a very important trial, and this is the East AF Net 4 trial, which looked at early rhythm control versus the conventional way we would treat atrial fibrillation. And it actually resulted in better outcomes if you did an early rhythm control strategy. And this was better in terms of strokes, in terms of heart failure, if we adopted an early rhythm control strategy. And if you look at this Kaplan-Meier curve, it shows that the cumulative incidence was lower when we talked about cardiovascular outcomes. So the population for this trial was actually patients who had early AF and they had a bit of cardiovascular comorbidities, and they were not primarily patients that we see who are quite sick with sepsis or in the ICU. And the rhythm control strategies used were multifactorial. And we realized that electrocardioversion is actually most effective in the hospital setting. And when it comes to pharmacological cardioversion, it's pretty much patient selective. But the whole idea is that we develop an early rhythm control strategy. So as I said, there are rules associated with cardioversion and anticoagulation. As I alluded to earlier, if you have AFib and it has gone on for more than 48 hours or even unknown, the strategy is to anticoagulate them for 3 weeks, or you can do a TE-guided cardioversion. And then they need to be anticoagulated for at least 4 weeks after. If it's somebody who has a CHAS2 VAS that is low, then you can stop anticoagulation at that point. But obviously, if their CHAS2 VAS is above 2, then you want to continue lifelong anticoagulation. So that also plays a role as well. So stroke prevention, as we know for AFib, is the highest yield intervention that we want to adopt. And therefore, with every patient that you see that has atrial fibrillation, you want to ask yourself, what is their CHADS VAS score? Because that's going to determine what their annual risk is for developing a stroke. And the DOACs are now preferred because these have a lower bleeding risk, especially when it comes to GI and cerebral bleeding, unless this patient has like a mechanical valve or rheumatic mitral stenosis. So if their CHAS-VAS is high, then you want to recommend anticoagulation immediately. That's a class 1 indication. And if it's intermediate, you can, anticoagulation is reasonable, but obviously if it's low, then you want to use monotherapy with aspirin. Well, actually, I think aspirin is actually not beneficial. So sorry, I should have said that. Aspirin is not beneficial if you have a low risk. So the other thing that we also look at is what is the bleeding risk for a patient who has AFib. People still use Hasbled. I actually do not use Hasbled. And the reason for that is that a lot of the things that make up Hasbled also are in the CHAS-VAS score. So for me, I look at the entire patient and what their protoplasm is like and see if they have any underlying bleeding issues, or if they have things that can increase their risk for bleeding long term. And I say that if somebody has bled, is not really a reason to withhold anticoagulation. So do we use DOACs versus warfarin? We do know that majority of the DOACs were actually inferior and one is superior to warfarin. And the only thing that I consider is what is this patient's kidney function? Because most patients who have chronic kidney disease or end-stage renal disease, most of the DOACs cannot be used. The two DOACs that I know of that we can use with patients with chronic kidney disease, and this is as low as the estimated GFR of 30, is apixaban and edoxaban. I know rivaroxaban also has a reduced dose. And then there's also things you need to take in consideration as well, is like what their weight is, especially if you're going to use a drug like apixaban. But we know warfarin is mandatory for mechanical valves and rheumatic mitral stenosis. So now how do we manage AFib in the ICU and perioperatively is a bit different. And this was a case of a 74-year-old lady who came in with septic shock, and she was placed on Levophed within the ICU, and she also had a heart rate of 160. It was irregular. ECG confirmed that she had atrial fibrillation. She's never had atrial fibrillation before. The question is, should we rate control? Should we rhythm control? And do we anticoagulate? All questions that, we kind of face every day. So for a patient like this, if they're in septic shock, I often tell myself, is this more than likely it is a catecholamine surge, and then they're also on norepinephrine, which can even drive that even more. The question is, when do we rate control? Most times I adopt a more rate control strategy because once this sepsis resolves, once this patient gets over their perioperative phase, they may either go back into normal sinus rhythm spontaneously, or they may continue to have atrial fibrillation despite their sepsis resolving. And I think this is somebody who may have an underlying substrate for AFib already, and their sepsis has kind of just precipitated it. So for those cases, those are patients who I may want to anticoagulate based on what their CHAS-VAS score is. So if it's a high CHAS-VAS, definitely going to anticoagulate in the long run. And then I may think about a rhythm control strategy based on the patient's symptoms and based on what their ejection fractions are. So why is ICU AFib different? And there's something I want you to remember is that if somebody has underlying atrial fibrillation prior to them being admitted to the ICU for any particular reason, and they develop atrial fibrillation with rapid ventricular response, this is a normal response. And that is because if this patient were in sinus rhythm, they would have a sinus tachycardia. So you want to recognize when to intervene and when to realize that this heart rate may be compensatory, because adding on a beta blocker may just make their ICU stay more prolonged because they're sicker, they can develop shock, and they can stay in shock for a longer time. So you want to be careful when treating AFib in the ICU. This is very difficult. For patients who have sepsis, I, again, rely on my CHAS-VAS score to determine whether or not I'm going to anticoagulate them long term. And even if they have AFib for a short duration, or if it's, not persistent, I often still think hard and long about not anticoagulating them. I would prefer to anticoagulate them versus not, because these are probably patients who would eventually have atrial fibrillation long term, or they may have had subclinical atrial fibrillation that we didn't know about. So the last case is that of postoperative AFib, and we see this quite common in cardiac and thoracic surgery, where patients develop atrial fibrillation probably by day 2. And the question is, do we rate control them versus rhythm control them with cardioversions? And when do we anticoagulate them? Again, It depends, and you have to have a conversation with the surgeons in terms of knowing what the best strategy for this patient would be. So for post-op AFib, my practical approach is usually treat a trigger. So is this patient in pain? Are they hypoxic? Are there any electrolyte abnormalities because of the surgery? So you want to correct your potassium, correct your magnesium, as well as phosphate, which we often forget about. And then rate control first, unless they're unstable, and then rhythm control can happen afterwards. And then again, anticoagulation is based on what their stroke risk and their bleeding profile is like. And when do you involve cardiology? I want to say in majority of the cases. I like dealing with AFib. It's, to me, one of the most challenging arrhythmias to deal with, just because everybody's different. But you specifically want to talk to the cardiologist when you suspect that they have underlying WPW. So this is AFib with an accessory pathway. If the person has refractory AFib with a rapid ventricular response, or if they have recurrent admissions for AFib, if there is a associated tachycardia-mediated cardiomyopathy, because we want to adopt a rhythm control strategy early, and symptomatic paroxysmal AFib, which I love to do ablations on. So this, again, is something that we want to be aware of. And then if this person has any post-op rhythm or flutter patterns that you want some clarity on. So I just want to highlight ablations in patients who have an associated cardiomyopathy or they have heart failure. There was the Castle AF trial, which showed that there was definitely improved outcomes with patients who underwent ablation for atrial fibrillation versus them being on pharmacological agents like amiodarone. And it showed that overall, and you can see from these Kaplan-Meier curves, that patients did better once they had an AFib ablation. So it improved outcomes overall when you talked about death or heart failure being worsened, or hospitalization for worsening atrial fibrillation. Patients definitely did better once they had an ablation for AFib. The Cabana trial was quite similar as well, where AFib recurrence was actually thought to be lower versus a drug therapy strategy. And most patients did better when they developed an AFib strategy for ablation strategy for AFib if they had paroxysmal AFib, or this was a first occurrence for atrial fibrillation. And we saw that there was also reductions in not only atrial fibrillation, but also atrial flutter and other atrial arrhythmias. And overall, after 5 years, their AFib burden had reduced when using Holter monitoring. So Cabana definitely supported atrial fibrillation ablations early on, so that patients can have better outcomes overall. So why do outcomes still vary despite us having guidelines? And the issue is that there is a system problem. There is variability in how the ED versus the ICU and how the wards manage atrial fibrillation presentations, and this causes inconsistent outcomes. In addition, there's also missed anticoagulation and follow-up. And I think this is something that we have to think about. How do we deal with this system problem? So the proposed institutional AFib pathway that I have in my head is that we want to look at that 10-minute proposal that I talked about, where is this patient stable or unstable? Do we adopt a rate versus rhythm control strategy? We have to document for each AFib case what their CHA2DS2-VASc score is, because this will determine whether or not they will require anticoagulation. And we have to remember the cardioversion anticoagulation rules, because the worst thing is to cardiovert somebody who's not properly anticoagulated, especially if their AFib length of time of having AFib is unknown or greater than 48 hours. And then we need to think about how do we follow up these patients? When do we involve EP cardiology so that we can talk about ablations? Because, we don't talk about it. And I guess this is something new because, we now have EP available. So we also need to develop discharge and follow-up templates so that we prevent bounce back, patients returning. And we want to have a rate control plan. We want to know what the target heart rate should be at the discharge and within the first couple weeks and months after discharge. Have an anticoagulation plan and counsel patients accordingly. And then also help patients to understand how they can also assist with managing their atrial fibrillation and do follow-ups with cardiology in a timely fashion. And then we also want to talk about how do we modify their triggers, or what plans do we have for their risk factor profiles. So if this person has obstructive sleep apnea, we want to deal with that as well, because we have seen in some studies that treating obstructive sleep apnea with CPAP has reduced patients having atrial fibrillation. So, you want to also deal with their high blood pressure, their obesity, and also alcohol use as well, if these are all associated with their risk for having AFib. So what are the pitfalls? We need to make sure that we do not give AV nodal blocking agents to patients who have WPW. Avoid diltiazem in heart failure with reduced ejection fraction in patients who present with AFib. You need to make sure, again, that if you're going to do cardioversion, you should not do it without having a proper anticoagulation strategy. And treating AFib rates aggressively can result in shock physiology. And having no plan for anticoagulation is a setup for disaster and patient potentially developing strokes. So key takeaways, unstable AF, cardiovert, that's a class 1 recommendation. Stroke prevention is foundational when we talk about atrial fibrillation and its associated morbidity and mortality. Lenient rate control is often reasonable, and we saw that with the RACE-2 trial. And early rhythm control is supported in selected patients. So we're talking about patients with heart failure with reduced ejection fraction or an associated tachycardia-mediated cardiomyopathy and heart failure. And ablation earlier is thought now to be great for some selected symptomatic patients. And this has now come from a class 2 recommendation to now class 1. So these are my references. And thank you so much for joining me on this very important talk on how we manage atrial fibrillation new onset. I am happy to take questions and any comments.
Okay, thank you. Thank you so much, Dr. Morris. You have definitely done a wonderful job in going through with us the management of new onset atrial fibrillation. We definitely love and appreciated the cases that you presented, and I'm sure each of us are far more clear in our minds as to how we are to approach the management of new onset atrial fibrillation. From early in the presentation, we had a question: why was the CTP angio done? What triggered same?
I have no idea. I do not know. But it was a good thing that it was done, because this guy ended up having bilateral PEs, ended up requiring thrombolysis. I think
Okay.
it was just part of It was probably part of what is causing his AFib because he didn't have any typical risk factors. I don't know if Dr. Bartholomew is on the call or any of her team members, but they can probably help me answer this question as well. They're probably not
Okay.
here. Yeah. But thank you
Okay.
for that question because had it been me, I probably would not have done it. Because I
Okay.
feel like this gentleman was within the age group to have AFib, at least getting there. He was 63.
Okay. We have another question. Why was thrombolytic treatment given to the 63-year-old ED patient?
Because he had a massive PE.
Okay, thank you. Does anyone have any additional questions and or comments for Dr. Morris? I know you were probably all very deeply in tune with the case as she presented it. Okay, it doesn't seem as if we have any more questions and or comments. Dr. Morris, you presented it very clearly. Everyone was taking notes, getting
Somebody has a
their...
comment.
Okay, there comes a comment. For patients with PE, would manage only be rate control as the clot can travel from conversion.
Yeah, so the only way for a clot to travel would be if this person has a PFO. So certainly you can, because this guy underwent a rhythm control strategy eventually. So he was electrically cardioverted. So I think for us in the beginning, it was mostly a rate control strategy because his heart rate was, I think, over 160 at one point. So that's why we did we did AV nodal blocking agents initially. So rate control. There was evidence of RV strain. Um, I think somebody just asked that.
Okay, we have a comment. Great presentation. And another question, was there right? Yes, there was it right there. Right ventricular strain. Was there pulmonary hypertension? Could his pulmonary issues precipitate a AFib?
Yes, certainly. So he could have had a PE first. What was not, what was unusual though was that he had a cardiomyopathy. And I feel like somebody having AFib for 6 hours is not a setup for having a tachycardia-mediated cardiomyopathy. It's just not how I imagine the pathophysiology to be. So is you have AFib that is not rate controlled for a long time, and that is what leads to your cardiomyopathy, not just 6 hours of having AFib. So,
Okay, thank you
yeah.
for that. And we also have the comment. Great presentation.
Thank you.
Very good questions, guys. Any more questions and or comments for Dr. Morris as she closes off Heart Month? Okay, good morning. Thank you for this presentation. I understand that you have a high threshold for those with AFib and who should not receive anticoagulation. What are your thoughts of DAPT for those with a history of falls?
I don't recommend it. I actually feel like dual antiplatelet therapy can increase the risk of having a stroke. So I don't recommend dual antiplatelet therapy at all for patients who have atrial fibrillation. If this patient has a history of falls, and depending on other risk factors as well. So we're talking about somebody who may be underweight, they have renal impairment. This is somebody who I would want to have a lower, like just a lower dose for anticoagulation if we're worried about them having some injury and developing bleeding on anticoagulation. So that's usually my strategy. So, for example, if I have an elderly person who has a history of falls, I want to adopt strategies to prevent those falls and then also give them anticoagulation on top of that. So, my preference is usually a Pixaban because it has a lower bleeding profile compared to the other DOACs. And you have the option of giving them 2.5 twice daily of a Pixaban with hopes that it is covering them for their AFib and preventing a stroke.
Okay, thank you. Another question for you, Dr. Morris. Does RV strain pattern raise doubts of acute PE?
No, it does not. So people can develop right heart strain with bilateral or saddle emboli. So even though right heart strain occurs, it does not necessarily have to occur with a chronic PE. So it can also occur in patients with an acute PE as well. Thank you for that.
Okay, thank you. Any more questions for Dr. Morris? I know they come rolling in just as I ask. Okay, I do not see any other questions and or comments for Dr. Morris. So at this time, I would like to remind each of you that this is an accredited CME. Please ensure that you change your name to reflect the name of that which is registered at the Bahamas Medical Council. Also ensure that you complete the feedback link. It's very important for you to complete the feedback link in order for you to be able to receive the credit associated with this presentation. Thank you, Dr. Morris, for spending the month of look forward to having you presentations.
Thank you so much.
I will see each of you at our next CME session, which will be the second Wednesday of this month. Do enjoy the rest of your day and have a wonderful week.
You too.